Hello, and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breitster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of today's webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. Today's program is Prevention Agenda 2013, a blueprint for community action to improve health in New York State. Our guests are Dr. Jo Ivey Boufford, the president of the New York Academy of Medicine, and Sylvia Pirani, the director of the Office of Public Health Practice at the New York State Department of Health. Thank you both so much for being here.
Thank you.
Now, the Prevention Agenda 2013 through 2017 is New York's plan to improve the health of all New Yorkers. Over the last few years, New York has been in the middle of the pack in national rankings of population health status. New York State ranks 18 in America's health rankings. But New Yorkers should have good health and as good a quality of life as those in the top-ranked states. You, New York's public health leadership, are the key to implementing a prevention strategy. Before we hear from our speakers today, we're going to take this opportunity to watch a short video discussing prevention. Let's take a look.
The New York Academy of Medicine was established in 1847 by a group of physicians who were concerned about the quality of care in New York. And since then, we've been very involved in a whole series of important public health issues in the city. Our current priorities are healthy aging, prevention, and eliminating health disparities. Prevention is, we believe, the key to improving the health of the population.
It's wonderful to provide access to care and treatment to people when they're sick, but it's also important to try to avert disease whenever possible, to prevent suffering and to prevent healthcare expenditures that could be devoted to other investments.
There are two important ways of intervening on prevention. One of them is personal prevention. The second very important area, and the evidence is increasing about how important this is community-based prevention. There's very good evidence that preventive activity makes a difference, and increasing evidence, especially in areas of tobacco, exercise, diet, and alcohol, that we can actually make interventions to create healthier communities that make the healthy choice the easy choice for everyone.
Prevention has really become a critical part of improving health care, and in New York State, Governor Cuomo and Commissioner Shah have been at the leading edge of efforts to capture savings for the health and healthcare system through prevention. Let's take a moment to hear from Dr. Shah.
Why is it important for New York State to have a prevention agenda? Well, we need to work together to focus our priorities to make any progress. 5 years ago, we had a prevention agenda that focused on 10 areas. This time, we're focusing on 5 areas and really making progress in short terms on measurable, evidence-based programs and policies that will help improve the health of all New Yorkers. Our prevention agenda focuses on 5 areas. First, on the promotion of healthy and safe environments, the prevention of chronic diseases, the promotion of healthy women, infants, and children, promotion of mental health and prevention of substance abuse, and the prevention of HIV, STDs, vaccine-preventable diseases, and healthcare-associated infections. What's new about the prevention agenda for 2013 through 2017? Well, this time we were able to work with over 140 different groups from across all of the communities of New York, including local public health, hospitals, primary care systems, to come together on what our agenda should be. The 5 areas that we selected were, at the end of the day, something that we all selected together. That's where the evidence is greatest, where we are best able to measure things over time and make an impact over time. Why is collaboration so important? You know, in the old days, it was all about creating niches and competing. Today, we know that success only comes from sharing and collaborating. Just look at Facebook, look at open government initiatives. And for us, we've decided that the prevention agenda has to embrace these principles, and it will only serve as a guide to local health departments and mobilize their community partners to assess health status, identify local priorities, and develop and implement interventions to address these priorities if we can get collaboration working across the spectrum. Hospitals and local health departments are doing this in conjunction with required community health assessments, community health improvement plans, and community service plans. In these tough economic times, one may ask, how can we take on these added roles and responsibilities? The answer is, we can't afford not to take on these roles and responsibilities. By focusing on a smaller set of priorities, we can actually move the needle much further than each of us working independently on our own separate programs that collectively don't make the impact. So what is my vision for New York State? Under Governor Cuomo's leadership, we've made significant strides in improving the delivery of healthcare services through our Medicaid program and improving access by building a health benefit exchange. But we know that the healthcare delivery system is only responsible for up to 20% of health. The social determinants of health, our behaviors and the environment, influence a vast amount greater than the 20% of the healthcare delivery system. Our hope with the State Health Improvement Plan is to focus on the behaviors and the environment and improve those over time to impact health in a much greater degree than just the healthcare delivery system. Thank you.
So it was really great to see both of those videos. I think they help to set the context for what we're talking about, and it's really clear from both of the videos that New York State is really working towards a prevention orientation. Now, Sylvia, Dr. Shah mentioned the importance of working collaboratively and working where the evidence base is greatest and so we can make the most amount of progress and measurable progress over time. Can you tell us about some of the urgent health issues and disparities that are driving the prevention agenda?
Certainly, Rachel. Let's take a look at some of the data that illustrate what issues are most important and where the greatest disparities exist. On this slide, you can see some of the most severe outcomes. This graph shows the number of deaths for some of the leading causes of death per 100,000 New Yorkers over the last 10 years. Heart disease, cancer, chronic lower respiratory disease, or CLRD, and stroke are all chronic conditions that are largely preventable and are addressed by one of our priorities, prevent chronic diseases. Pneumonia and influenza are vaccine-preventable infectious diseases and fall under the fifth priority group, prevent HIV, sexually transmitted diseases, vaccine-preventable diseases, and healthcare-acquired infections. And unintentional injuries round out the group and are often behaviorally modifiable and fall under two different priorities, the one that promotes a healthy and safe environment, and another one promoting mental health and preventing substance abuse.
So when we look at that big picture and those leading causes of death, how many of them would you say are preventable if we were able to modify behaviors?
A national study published in the March 2004 Journal of the American Medical Association found that 46% of actual causes of death are attributable to 8 modifiable behaviors. This slide shows you the estimated number of deaths in New York State due to modifiable behaviors. Tobacco, diet, physical activity, and alcohol contribute the most to the estimated number of deaths. And each of those 8 modifiable behaviors that you see in the slide link to one or more of the 5 priorities of the new prevention agenda.
Now, in looking at that chart, tobacco is really leading the pack there, if you will.
Yes, it is.
Can you talk to us a little bit about tobacco use in New York State?
Certainly. You're going to see on the next slide the age-adjusted percentage of current smokers in New York State. The darker the color on the map, the higher the rate. The overall current smoking rate for the state in 2009 was 17%, but what you see on the map is that some geographic disparities exist. The county rates varied from the lowest rate of 9.7 among Rockland County residents in the Hudson Valley to the highest rate of almost 31% in Chemung County residents in the southern tier. In general, our upstate counties had higher rates of current smokers.
Now, when we look at these different health conditions, whether it's tobacco use or otherwise, it's true that they don't affect all New Yorkers at the same rate, or they don't affect all New Yorkers equally?
Correct. We have a lot of disparities in health conditions in New York State. We have unacceptable disparities, for example, for people who have health disabilities. And the next slide will show you the disparities for that group compared to those people who don't have health disabilities. So the blue bars are the indicators, the rates of disease for cigarette smoking, for example, or obesity for those with disabilities, and the red bars are the rates for those without disabilities. So you see in some cases almost double the rate of these diseases.
Which is pretty, I mean, that's a pretty staggering disparity to look at it, you know, to look at the chart like that. Now, there are other conditions as well that disproportionately affect certain groups. Can you talk about some of those?
Sure. We have many disparities in different diseases in New York, unfortunately. Health disparities exist for different outcomes, such as premature death, for example, before the age of 75 for the American Indian group versus the white non-Hispanics, the high breast cancer incidence for whites versus others. What you see on this slide that just went up is heart disease death rate. Even though the rates have been declining over the past decade for all racial ethnic groups, disparities still exist. And in 2009, the heart disease rate was almost 2.5 times higher among the black non-Hispanic group, which is the top of the graph there in pink, compared to the Asian non-Hispanic group at the bottom of the slide in the dark red color.
So clearly some big picture issues to look at with all of the different disparities that you've talked about.
Absolutely.
Now, Jo, in addition to looking at health status and health disparities, what were some of the other things that went into consideration when you were developing the new prevention agenda?
Well, we really wanted to start by looking at what worked and didn't work the last time between 2008 and 2012. And at that time, as the commissioner said, the plan included 10 priorities, and so we decided to narrow in on 5 priority areas for this part of the plan. So, as he said, to get more concerted action to really see the results at the community level. Collaboration was an important theme for the first prevention agenda. But in fact, the plan was largely developed by the State Health Department, and we did bring in a group of organizations and individuals statewide to help with implementation. And we knew we needed to start this process earlier this time around. As we looked at the outcomes reported at the local level of the planning process, it was clear that many local communities, the hospital directors, the public health department directors, did work together, but in others it was more difficult. And in many as well, they were not able to bring a lot of other community institutions or individuals to the table. So that had to be a focus of concern. And part of the reason was they needed more support, more technical assistance on the partnership issue, on setting priorities, on implementing, developing implementation plans, and on evaluation. So we've, again, paid a lot of attention to that in this new plan.
So how is the development of the plan different this time around?
Well, we started with the plan really being led from the very beginning by an ad hoc committee of individuals and organizations statewide, and they were officially appointed by the Public Health and Health Planning Council. So they had this status working in partnership with the Public Health Committee members and included key leaders around the state in the hospital industry, in health, public health, and professional associations, state networks of advocacy groups concerned about various health issues, professional associations, and the business community. This group met 4 times during the course of about 18 months to really help shape the initiative from the beginning, and they reviewed and approved the final draft of the report before it went to the State Public Health and Health Planning Council in December.
So it seems like you certainly got a lot of people involved in the process. Can you tell us why it is so important to have such a large group of people helping to form the new plan?
Well, broad participation is really important because of the creation of in creating the plan, we really wanted to tackle the many determinants of health beyond the personal health care system. So this diagram that's going up is from a very important paper by Dahlgren and Whitehead, and what it says here is that if you look in the circle in the middle, we're really born with some kinds of attributes that can't be changed. Age, genetic makeup, sex, and race and ethnicity are also factors. But as soon as the child is born, these influences from their families, from their communities, begin to have a strong influence on their health status. And when we move out into the community, we begin to see that wider influences on health that shape resources available in communities like housing, workplace conditions, crime, and public safety, and the availability of healthy food and places to exercise are all really shaped by health policy. And the weight of the evidence is getting to be pretty convincing that we've got to act on these factors if we're going to see results in the community's health.
Now, isn't the health agenda, the prevention agenda, really a government initiative, though?
No, not really. Some people think, and I think we've seen here in New York, that while the governmental public health agencies are sort of the backbone
of the public health system. The concept now is that the public health system really has to include multiple stakeholders. And on the next diagram, you can see the model that's really been built by the U.S. Institute of Medicine. And it really states that you've got to try to identify for any particular health issue where the resources are in a given community to develop a plan and begin to implement the plan. So again, you see the same list of stakeholders: business, academia, community-based organizations, the healthcare delivery system, which in New York is a major factor. And the challenge of developing the prevention agenda will be really aligning the interests of all of these potential actors at the community level to really get the highest health result for individuals and for that community.
So I have to say, listening to everything you've just shared, the scope of this sounds very ambitious.
It is ambitious, and I think happily we were able to really take advantage of what we've learned since the last time the prevention agenda came through. And we've really been using a model that requires each of the teams and groups that are looking at the big 5 goals for New York State to really look at a wide range of interventions. So we've been using this pyramid structure, which was developed out of the Centers for Disease Control, as a framework for action at the 5 levels of public health systems. One is, if you start at the top, we see the engagement with personal counseling and preventive services, which are emphasized certainly in the new healthcare reform at the national level, such as immunization. As we begin to move further down the pyramid, we see that we bring individuals into looking at the circumstances they live in their communities. How can we change environments, clean water, safe roads, availability of healthy food so that the healthy choice is the easy choice for them. And then as we move even further down, we really confront this sort of outer circle, if you will, of the last diagram, where the policies that create the conditions in communities become more and more important. So every plan for each of the 5 objectives really has to include action at each of these levels, because if we can act at the same time and align our interventions, we have a much better chance of making a difference.
And I understand there have been efforts made to quantify or to evaluate how the community factors affect health outcomes as well. Can you talk to us about that?
Yeah, there is a very interesting project out of the Population Health Institute at the University of Wisconsin called County Health Rankings, and they have produced a report for each of the states, including New York, over the last 3 years. And this report really tries to illustrate how important community conditions are in influencing the state of health of individuals. So if we look at the diagram that kind of lays out these variables, if we start at the top, the overall score really relates to health outcomes, the mortality rates in a community and the morbidity rates in community, and how they rank within the state. And these are developed by equal weightings of what are called health factors. And if you look down the middle of the diagram, you see these issues of health behaviors, clinical care, social and economic factors, and the physical environment. And each of those are further defined on the right-hand column. So a score is possible for each of these areas, and the weighting, as I mentioned, really reflects, again, this pyramid, this impact that we know of acting at the individual as well as at the policy level. So the scores are aggregated, and they yield scores for each county. And then we can begin to develop a map, such as you see here, which is the 2013 map of New York State's rankings. And the dark green are the counties which are having the worst time with these health and social variables, and many of the causes are often related to poverty. And these are important issues that require concerted action within the community, and also the kind of policy support that we hope the prevention agenda will motivate.
So that's really a really helpful way to conceptualize what you've been talking about and see in green on our slide, but in black and white really how these issues affect different communities. So what is this, you've got this broad partnership of all these people invested in the prevention agenda. What do you really hope to accomplish?
Well, this broad-based group that I mentioned developed really 4 goals for the plan. We want to see certain things happen while this process is ongoing. And the first, of course, is the overall purpose, which is to improve the health status of all New Yorkers in the 5 selected areas, and especially to tackle the issue of health disparities. We sort of agree on a vision of making New York the healthiest state, as you said, getting it out of the middle of the pack. The second goal is really to begin to tackle these broader determinants of health, and the term health in all policies is often used to reflect the fact that in the areas of agriculture or food safety or housing or transportation, air quality, built environment, there are decisions that can be made in all of those areas in a particular program or policy. Is this going to help promote health? And our job is to really get these other actors to understand how what they're doing really can contribute to the health agenda. The third area is that we want to leave behind a very much stronger public health infrastructure at the state and local level. We know that public health is not as well funded as we'd like, and the public health agencies are really pulling together here to get results, including the involvement of the Department of Mental Health and the Office of Substance Abuse Services, which are engaged in the 4th goal area of the state plan. The partnerships that have to be created among all of the actors that we've talked about, we want to see them sustained, so it isn't a one-off exercise that they get together because they have to submit a report to the state, but they really begin to develop relationships and see that working together in a community, they can make an enormous difference. And finally, as this diverse group sat around the ad hoc group, we realized that we probably weren't making a strong enough case about the importance of public health and prevention, so that we really had to think about how do you make the case to business, how do you make the case to those that aren't as familiar or as committed to our interests. And one of the really significant things is, again, an increasing understanding of what you might call the return on investment for every dollar invested in community-based preventive services on things like tobacco, exercise, and diet that Sylvia mentioned. There's a possibility for all payer savings of almost $6. And this can happen in a fairly short time period, 2 to 5 years. And this is very different understanding of what the time frame for real prevention results than we've had in the past. So it's very encouraging, and it gets people motivated.
Excellent. So now how does this fit in with other health initiatives at the federal, state, or even local level?
Well, we looked at those because context is everything when you're trying to start an initiative. And the first thing we did was really look at national health care reform, and the Affordable Care Act really does provide a lot of messages and a lot of unprecedented funding for preventive services, and this is certainly influencing the state waiver and the state application. We can see that in the Medicaid redesign program. So for example, individuals now should be getting age-appropriate preventive services without any copay, regardless of their insurer, and that's a huge change. The agenda also tries to align local programming efforts and build up on those programs. So for example, the State Health Department with state and federal funding supports programs like Healthy Heart or asthma control or maternal child health initiatives and vaccination. And the prevention agenda really hopes to be a call for action to help those groups really see how they can connect their own plans with the state prevention agenda, especially in their own communities, because that's really the essence of success of this program. And the work will be anchored by the community service planning and local health department community health assessments, which the state has asked the hospitals and local health directors to conduct.
So Sylvia, can you talk to us a little bit about the local community health planning efforts?
Certainly, and Dr. Shah talked about this as well. We have required in New York State that local health departments and hospitals conduct community health assessments and planning at least since 1986. What is new this year is that the prevention agenda is requiring them to do this collaboratively. The prevention agenda provides a blueprint for how to assess health status, identify local priorities, and develop a plan for addressing them. So we're really hoping it's the toolbox for them to take out in their local communities. At the beginning of this planning process, in December, Dr. Shah sent out a letter to hospitals and health departments requiring them to work together on this and asked them to identify in their process at least 2 prevention agenda priorities that made sense based on the data in their community. One of them has to address a health disparity. So that's how we're setting it up this year for that local planning.
Great, thank you. And some of the work that Sylvia discussed is happening close to us here in the Capital Region. We had the opportunity to speak with Jim Connolly about the You Matter program and Ellis Hospital in Schenectady County and some of the great work that they are doing. They recently hosted a press conference to introduce the You Matter campaign. Let's take a look at that right now.
Our program, the You Matter program in Schenectady, actually mirrors a program that I first saw in Chicago. The Sinai Health System in Chicago for the past 10 years has been engaged in this kind of a program. The principle of it being that there is a great deal of health-related data and a lot of different databases, but that data sometimes does not cover significant diseases in the community. In fact, sometimes the data masks the diseases that exist in the community. And some of the people who actually are experiencing those diseases, that they don't have anybody to advocate for them and bring those diseases to light. The best way to unmask this data, to bring these things to light, is to do a neighborhood by neighborhood, door by door survey to really assess what people's needs are. I think what's different about this approach is it's not being driven by an institution. This is not an institutional program in assessing the community's health. It is very much driven by the community. The hospitals and other healthcare providers are facilitating it, we're enabling it, we're supporting it, but it is not our particular program. We're not actually conducting the program. It's being conducted by a community-wide coalition. And it is a door-to-door survey as opposed to just looking at databases and abstracting the data. It's not to say we won't look at the databases, but it's being meshed with person-to-person interviews. And I think the last thing that's different about our initiative is that we're actually using people who live in the neighborhoods. We're having neighbors ask neighbors these questions, and these very same people that are asking the questions are also going to be people who help kind of screen the answers. They'll be able to determine when an answer is truly reflective of the same kinds of health issues they're facing and make sure the answers are truthful and accurate. In the long run, this will mean that people will not need to use the hospital as much, the ER, be admitted as often, their chronic illnesses will be better managed, and that's a good thing in the long run because it'll drive down consumption and drive down healthcare costs. Of course, in the short run, that may hurt us because it's obviously things that we get paid for that will disappear, but we have to adjust our business model. I think this program aligns with the prevention agenda because many of the things that the prevention agenda called for are sort of cornerstones of this community health initiative, trying to keep the population well. So we are carrying out at the grassroots level all the things that have been identified at the federal and then state and county levels, and then we have worked with the county in the past to roll out into our community. So in terms of the principles of what you're trying to do, it aligns, I think, perfectly with those health principles, those health guidelines. In terms of collaboration with the community and to create a collaborative community planning process, I mean, this doesn't get much better than this because a lot of time and attention has been paid to this initiative because even though Ellis is involved, even though Hometown Health is involved, even though the Department of Health is involved, it is a community-driven organization, and it's very, very apparent that the institutions are not in control of this thing, they're facilitating it.
So it's clear to me, at least, that Schenectady County, Ellis Hospital are really doing some great work, especially incorporating the things you guys have both been talking about, working at the community level and getting that collaboration. Sylvia, can you talk about how the 5 specific priority areas were identified and how local communities can use that information in developing their own or addressing their own priorities?
Certainly. Jo talked a little bit about the ad hoc committee that we had that actually helped identify the 5 priorities based on that data. And once the priorities were selected, we invited a whole host of additional people, there were over 200 actually, from a wide range of sectors to develop the priority-specific plans. We had excellent participation from colleagues in public health, in medicine, community-based organizations, several business representatives, some media, so we really, again, did that collaboration that made such a difference. We organized these people into 5 different committees, one for each priority. They were chaired by pairs of people, one from the government sector, one from non-government, and they led a process over several intensive months, July through September, to develop priority-specific action plans for each priority. We had a steering committee made up of the chairs of each of those 5 committees and some other people to address cross-cutting issues and to keep us moving. And we were funded in part by the Robert Wood Johnson Foundation, which supported our efforts.
And can you describe for me and for the audience what is in each of the priority action plans?
Certainly. We developed a set of tools for each priority area, and they include the following. For each priority area, we have focus areas. We then have goals, measurable objectives or metrics for each of the goals, and a set of evidence-based interventions. And those are sorted both by the sector or the stakeholder group and then by the health impact pyramid that Jo talked about. And before walking you through an example of this tool for the chronic disease priority, I wanted just to spend a few minutes to talk about interventions.
Sure, I think that would be great.
The list of interventions are evidence-based approaches for consideration. The purpose was to suggest actions for consideration at the local level, but not to be prescriptive. Included in the list of interventions are the background resources where you can learn more about them and how to adapt them in your community. Each community is going to consider its own circumstances before selecting the interventions from the menu that we provided, and we are anticipating that partners sitting around these local tables will expand and refine the list through their implementation. Now I want to walk through a complete example of one priority area for chronic disease so you can see what's included.
Sure, I think that would be really helpful to illustrate how this is all going to come together.
Okay, so for the prevent chronic disease priority, there were 3 focus areas. The first has to do with reducing obesity in children and adults. The second has to do with addressing tobacco use and secondhand smoke. And the third has to do with increasing people's access to high-quality chronic disease prevention and management in both clinical and community settings. So I'm going to talk about reducing obesity in children and adults, which, as you saw in that other slide, is a huge factor in contributing to illness in New York State. One of the goals for the Reduce Obesity in Children and Adults is to create community environments that promote and support healthy food and beverage choices and physical activity. That's the goal area there. And we have several objectives for this goal, and I'm just showing you here just one. We have an overall objective for adults, which you can see is to reduce by 5% the rate of obesity. And then we have some sub-objectives for those people with low incomes under $25,000, and another one for people with disabilities. And again, you saw in the previous slide on disparities that people with disabilities suffer disproportionately from obesity. So we wanted to have a specific measurable goal so we can track our progress in addressing it. Mm-hmm. And then we move on to interventions. For the particular focus area of reducing obesity in children and adults, we have sorted the interventions by that pyramid that Dr. Boufford discussed earlier. So what you're seeing here is the top of the pyramid. Here are some of the interventions for reducing obesity in children and adults in, say, the second level clinical interventions. We want those in the clinical field to increase the capacity of primary care to implement screening, prevention, and treatment measures for obesity. And again, there are many more interventions in the plan. These are just a couple that you could choose from. Mm-hmm. And then the next slide shows you the bottom of the pyramid, where you can see interventions to implement that relate to changing the context to make individuals' decisions healthy. Jo spoke about this. This is about improving the community so people can make the healthy decision. And in this case, we focused on business models that support increased use of healthy, locally grown food. And the socioeconomic factors, which, as difficult as it might be to address, we have to focus on that as well. So it's best to intervene in as many levels of the pyramid as possible to have the biggest effect.
And there are interventions by sector as well?
Yes. So we also sorted them the second way, by sector. When developing a local plan, those community groups at the table will be able to say, if I'm a healthcare representative, here's something I can do. Adopt hospital policies to change the food we serve in our cafeteria to both the public that comes in and to the patients who are served in that hospital. That's a huge effort. Sure. Media can support us by doing public service announcements to promote healthy eating or breastfeeding. And then you can see the other slides as well. There's interventions for academia, for government agencies, and then finally the final slide in this group for the non-governmental sector, policymakers who are very important, communities, and philanthropy. So we've really identified an evidence-based or a promising practice for each of the sectors that we hope will play a role in these community collaborations.
So it certainly seems like it's very well laid out and a nice linear format for people to follow along and say, okay, this is our goal. How are we going to get from point A to point B?
That's right. That's what we're hoping for. We're hoping that it's a useful document. And then this final slide I wanted to share with you is back to the pyramid, where you can see all the sectors that we really want to engage. Here you see all laid out what each sector's role can be in addressing obesity prevention, and it's another way to summarize what we've done.
Yeah, and I think looking at it that way, it's a very helpful way for folks to see exactly where they fit into the picture of moving things forward towards the goals of the prevention agenda. So I think that was a very helpful look at how chronic disease is being addressed through the prevention agenda. At this point, I think it would be helpful to turn to an example of Schenectady County and their ARC and how they've implemented a program to use some of the interventions we've discussed. So let's take a moment to hear from staff and participants in that program.
This project really relates to the Decreasing Chronic Disease Prevention Agenda item. That is one of 5 items on the prevention agenda. Here at Schenectady ARC, we're working with a group of individuals who are developmentally disabled that are disproportionately affected by chronic disease. And this project really looks to mitigate that chronic disease by increasing their access to fresh produce.
The pilot program that started in 2010 involved around 70 plus individuals. It varied depending on the stage of the program. At the end of the program, we found that the vegetables were distributed, I would say, to almost every group home we have, and there are 21 group homes operated by Schenectady ARC, as well as our day programs. So they were sent home to the group homes. They were sent to family homes as well if our participants lived with their families or caregivers, and they went back to the day programs. So we benefited an incredible number of our participants through this program, and we did note that they tended to want to eat vegetables on a more regular basis.
We got 20 houses, and we try to send them to each house. And I can see they eat healthier because they ask for the vegetables now. I love it in here. It relaxes me so much. I grow vegetables, flowers. I just get my hands dirty.
The collaboration between Schenectady ARC and Schenectady County Public Health Services is a new partnership that we've developed over the last 3 years that has proved invaluable to us in the Strategic Alliance for Health. They've really taken their experience with horticulture and spread it throughout the community and have been working with other partners as well.
No Grow and Eat Your Vegetables is a very economical program. We have a horticulture coordinator who works side by side with the participants through the entire growing process, teaching them how to cultivate a plant, water a plant, harvest a plant. That's part of the requirement, and that's an in-kind expense through our agency. So that individual is providing that service, and this becomes part of our day program. We obtained a small grant from the Schenectady County Strategic Alliance for Health, and we proceeded to create the No Grow and Eat Your Vegetables program.
Before I started working here, I was eating bad, really bad. And after I came here and we started eating, I was eating green. Now I'm eating green. And my health very much improved just by gardening and learning how to eat better. I can do a lot more stuff. And I can eat a lot better, and I don't eat garbage.
We're really looking at designing our community health improvement plan through a health equity lens and looking at populations that are underserved and are highly affected by these chronic diseases. So these innovative programs allow us to do that.
It was really great for us to be able to go out there and talk to both those who started the program, who are working in the program, and even folks who are participating in the program. And I think it really helps to put a face on how is this plan coming into action. Let's take a moment now to move beyond just chronic disease and talk about some of the other priority areas.
Certainly. One of the priority areas that was new to include in a state health improvement plan was the promote mental health, prevent substance abuse priority area, because it's not something usually that we in the health field think that we can address, but this was really a great collaboration with the Office of Mental Health and the Office of Alcoholism and Substance Abuse and many other stakeholders in this arena. Mental and emotional well-being are essential to overall health, and many of the communities have told us that we have to include it in our plan. Nationally, at any given time, almost 1 in 5 young people is affected by a mental, emotional, and behavioral disorder. So we really needed to address this. So we're pleased that it's part of this plan. And we're really focusing on prevention, not treatment in this plan.
Excellent. And what about a goal around preventing infection or disease?
Yeah, so as Jo said, this is maybe one of the more traditional public health issues, but we've combined many of these into one here, and we had, again, a broad range of stakeholders helping us address this. So we hope we can move the needle on this. New York remains at the epicenter of the HIV epidemic, ranking first in the number of persons living with HIV/AIDS. The same behaviors and community characteristics associated with HIV also place individuals and communities at risk for STD and viral hepatitis. And while high immunization rates, of course, has been a goal forever in New York State, we're below the national goals on our immunization rates for very young children. That's why this needs to continue to be a priority. And we're focusing on healthcare-associated infections at this time as well, because they're preventable, and we continue to experience a large number of infections and associated deaths with those.
Sure. And what about promoting health in women, infants, and children?
Included in this priority area is a recognition that key population indicators for this area have been stagnant recently. And this area includes goals related to reducing preterm births and maternal mortality, promoting breastfeeding, increasing use of comprehensive child health services across the state, reducing dental caries, which is huge and should preventable, preventing adolescent and unintended pregnancies for both teenagers and women, and then really focusing on women's health, not just maternal health, but increasing use of health care and appropriate prevention for women of all ages and all stages of their life.
And what about, I know we had some discussion earlier about the role of the environment and what that plays in, it's not just the characteristics you're born with, but there's all these environmental factors. How does that fit into the priority areas?
Yes, thank you. The Promote a Healthy and Safe Environment tackled some of the more traditional environmental health issues, such as air quality and water quality, but also tackled the environment we build around ourselves, from homes to workplaces to roads and parks. So they're really talking about the built environment. They're talking a little bit about climate change. They focused a little bit on, especially after Superstorm Sandy, this is a really important priority area. They also, as Jo mentioned, included the word safe in this to focus on reducing both intentional injuries related to violence and unintentional injuries, especially as people age. And this is an important priority for many communities around the state.
Well, it sounds like a lot of thought went into these priorities, because they certainly seem right on point with everything you've been discussing so far, but also seems very ambitious. So what are the plans to measure progress on these goals?
Measurement and accountability are at the heart of this effort. Each committee, with tremendous support from our Public Health Information Group staff at the Health Department, worked to identify relevant indicators for each focus area and came up with measurable objectives. And there are many measurable objectives in the plans, but we are going to track 58 of them annually, so we'll be able to report on those and keep track of our progress.
And what data on health indicators are available to counties to help them in their planning?
The data that are available for counties are available on our website. We've identified data both at the statewide level and both at and the county level. So what you're going to see on the slide is an example of a Prevention Agenda County dashboard for Albany County, and there's one for every other county in the state. The link is on the slide. The table contains data for 65 individual prevention agenda tracking indicators with baseline county data, comparable state data, and the overall state targets for the end of the 5-year period. So there's links to data tables, there's links to maps, so you can better visualize what's going on in your county compared to other counties.
Excellent. And is there a Prevention Agenda website as well that you wanted to share?
Sure, there is indeed, and we've been working hard on improving this. This is the part of the website that you see here, and where the arrows show you is how to get to those dashboards and the data.
Excellent. I think that'll be a very useful resource for folks. And just a reminder, we know that some of the images can be hard to see on the screen as it's broadcast to you, but all of the handouts are available on our website as well if any of it's not so easy to be seen on the screen. Now, it seems like there's been a tremendous amount of work that's gone into developing the plan, but when we look at what the plan has laid out, I would imagine a lot of the really hard work is going to come in the implementation. So can you talk to us a little bit about that?
Yeah, that's really a focus because, as I said earlier, one of the things we found out the last time around was that many communities had difficulties and challenges. Now, the work that Sylvia and her colleagues have done to really create these amazing resources, I think will help because people can take them and then adapt them to their own situation. But part of, while grounded in the hospital and local health department responses, because of the state requirements, we've started a community communications plan, a broad communications plan, which begins with the hospital. So Greater New York Hospital Association, Haney's, the New York State Association, and NYSHO have already begun webinars really explaining to their members and constituencies about the prevention agenda and the roles that they can play. There have been broad-based presentations, consultations throughout the state to multiple audiences. We've been really gratified at how the ad hoc leadership group have invited folks from the health department and from their colleagues to come and talk about the agenda. We also, the health department will also be rolling out a communications plan which has been funded by the Johnson Foundation and with support from the Rabin Martin firm, who are some experts in communications processes. We hope to really engage all of these multiple sectors in ways that help them, help us understand what health means to them when you talk about it, and then help them understand the role that they can play at the local level. The steps in the plan really start with the idea of understanding the health concerns of some of these other groups. So in the slide that you'll see, the first step is really having conversations and really understanding what do they mean by health and what are the issues that are going to happen. The second step was really developing a strategy to identify statewide and national opportunities to promote the prevention agenda. A third step is developing a toolkit, which we hope will also be very helpful to communities in addressing health disparities. A set of media spokespersons from each of the sectors will be identified and trained, and we hope to get them on the circuit and get them around so that they can really share the message with the communities. And finally, as you've seen, there will be continuous development of web content and media, and we really hope to be we will be seeking additional funding to really make the websites more interactive and capable of collecting the good practice that's going on around the state in each of these areas and sharing it across communities.
Excellent. And one of the other things you had mentioned was technical support. Can you talk about that a little bit?
Yeah, again, really looking at what wasn't available the last time. Mm-hmm. A proposal has been put out by the health department asking for organizations who can operate either at the regional or statewide level to provide support to local community health coalitions in their work on the prevention agenda. So they will use multiple techniques, meetings, we hope some in person, and webinars. The key topics will be coalition building and the challenge of developing and sustaining partnerships, especially the kind of broad-based partnerships we want to see. identifying priorities and using the data sets that are available to them to make it easier to identify and design interventions. And then finally using a continuous quality improvement approach to the testing and implementation, and especially the measurement of performance on this agenda. So all of this work will be going on over the next 9 months as the plans are really being developed, and we hope to be able to continue again with additional funding, the technical support during the implementation phase. We've developed a very important partnership between the Public Health Council and the Minority Health Council on really working together to tackle the issue of health disparities and develop a specific framework and tools that local communities can use for that purpose.
Now, you've both covered a tremendous amount of information today. So is there a place where people can go for more information on New York State's prevention agenda?
Yeah, the homepage of the New York State Health Department now has on it a very big blue button, which we worked very hard to get there. So that should really be seen as your portal to the prevention agenda. When you push that button, you're in, and you can access all the materials that Sylvia's shown and that have been discussed about each of the 5 priority areas. And then there are a series of other resources in sort of subsequent slides here to begin to answer some of the questions. Some of them come from the State Health Department, and others, very importantly, come from other hospital associations, community health organizations at the national and regional level. And then in the next slide, on data resources, again, the county rankings data, videos that may be available. Obviously, the records of telecasts and broadcasts like this will be available for the use of local communities. And we really hope to continue to develop the capability and flexibility of the website to serve the purposes of those who are going to be working so hard together and really breaking ground in very important ways to implement the prevention agenda.
Great. Thank you so much, both of you, for all of the information you've covered.
You're very welcome.
We do have a couple of questions that we've gotten, and so if you don't mind. The first was, how would you describe a health disparity? I live in a county that's predominantly white, and I need clarification on how this information regarding health disparities affects me and relates to my county.
That's a very good question. Thank you, whoever asked it. Health disparity is really defined as the difference in health status between different population groups. Sometimes it's measured by just the difference, sometimes the ratio of difference. You can do it different ways. But really what's important here is that we're talking about different population groups, not just racial, ethnic minorities or majorities in some counties. Mm-hmm. We're talking about socioeconomic status, which is very important, especially in rural communities. We're talking about people with disabilities. We're talking about zip codes in some areas, mm-hmm. So people who live in one part of town versus another part of town. So if people can demonstrate that disparity, sometimes it might be related to transportation or access to the
Sure.
service. So I think people can describe and define the disparity, how it makes sense in their community. We're certainly not only talking about race or ethnicity.
Great. I think that's a really helpful way to clarify that. We have another question. What were some of the challenges that you saw in creating partnerships at the local level?
Well, I think in talking with people who've been at this is the first round, and we're happy to hear that. I think this is changing. Originally, in some communities, hospital leadership and the local public health leadership had never really talked to each other, and sometimes they didn't know who the other one was. So I think in the first round of the prevention agenda, a lot of those barriers were broken down, and hopefully some of those relationships have been sustained and are going to make it much easier in the next round. And I think the work of the hospital associations and the Public Health Association in really raising the profile of the agenda and the importance of these partnerships as kind of the anchor in communities is going to be very important. The second challenge, which the ad hoc committee has been very concerned about, is how do we bring those other groups that were in the bubbles that you've looked at to the table. And so we're hoping by also involving the state level networks of those organizations and community groups and individuals, really, that they will then be able to tap in to the local chapter, to the local individuals, and really begin to come to the table and knock on the door of the local hospital director mm-hmm. or the public health director and say, I understand this prevention agenda is going through. I'm working on obesity, I'm working on heart disease, I'm working on food safety, and I want to be in the conversation, and that those will be sustained. So that's it's going to be a lot of work. We know some communities are already doing it very successfully, and
Schenectady, for example.
Yeah, I think Schenectady was a lot of really
Right.
great examples of people working in the right direction.
And we've heard that going through, and I think the hope is that those that are working well will be able to spotlight what they're doing, and they can share their experience with their colleagues and make it easier for the others.
Excellent. Well, it seems like a lot of really great work is going to start happening. There's been a lot of work that went into developing the plan, and I thank you both so much for sharing all of this with our viewers. I think it's been tremendously helpful.
Thanks for the opportunity.
Sure.
Thank you.
And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's program. This webcast will be available on demand on our website within 2 weeks. Please join us for our next broadcast on April 18th. I'm Rachel Breidster. Thanks so much for joining us on Public Health Live.